In this video, I'm going to discuss the Aspergillus species. You've probably heard a decent amount about Aspergillus from Dr. Gupta through practitioner content and from Dr. Poole through pathology content, um, basically relating to asthma and Aspergillus bronchopulmonary syndrome. But now I'm going to kind of talk about it more from the mycology standpoint and the infectious standpoint. So one of the things that makes Aspergillus kind of an important pathogen is that it's actually the most common invasive mold infection worldwide. It's ubiquitous mold found throughout the world. We can find it literally everywhere. It's in the air, in the soil, in the water, in decaying vegetation. It's everywhere. So anytime you have a pathogen that's literally everywhere, that like you can't go anywhere without coming in contact with it, that tells you that for the most part, most of us are not getting sick from it. Or if we are getting sick, we're getting over it very quickly. So who are the people who are actually really struggling with this one are patients who are immunocompromised. This is largely considered an opportunistic pathogen of specific subsets of patients. It has kind of an interesting look in tissue in both its yeast and mold forms. So you can see these septate hyphae branching at acute angles. I'm not showing that here, but I'll show that later. But it also can create kind of this fan structure in tissue, which is also kind of identifiable for Aspergillus. It's a highly aerobic organism found in almost all oxygen-rich environments, like I mentioned. And there are a whole bunch of different Aspergillus species, over 900, but there are really only 4 that are of importance clinically. So A. fumigatus, A. niger, which actually produces kind of like a black pigment, A. flavus, which actually produces like a yellow pigment, and then A. terreus. So that's kind of the main overview of what it is. Because it's worldwide, there's no specific epidemiologic location associated with it. It can be found in food, potted plants, spices. One of the things that has kind of shown up recently is that you can find it in like marijuana plants or soil associated with that through like dispensaries and growth. Damp cellars, attics, all these places where it might kind of localize. And it has been transmitted to patients actually in air ventilation systems and then also through local construction sites because it's just kind of everywhere. So it's acquired through inhalation of aerosolized conidia. The conidia are actually going to settle into the lungs and the nasopharynx and the sinuses, and they can cause disease in each of those places. And they're actually really good at kind of hanging out there. They can bind to the fibrinogen and laminin in the alveolar basement, and that actually allows them to establish residence in the tissue because they have kind of like a foothold. We can combat against it fairly effectively. Macrophages and neutrophils are incredibly important for this. The macrophages are actually able to ingest and kill the conidia, and the neutrophils will actually adhere and kill the hyphae. So we can actually attack it on 2 fronts, which is pretty exciting. However, if you get kind of overwhelmed, if your neutrophil response gets overwhelmed by the amount of hyphae, it's actually a fairly invasive organism. When the hyphae aren't killed, they actually invade both the pulmonary tissue and the vasculature. And when they invade the vasculature, that actually leads to thrombosis, local tissue necrosis, and actually, more importantly, hematogenous spread. So once that hyphae is into the bloodstream, it can actually spread to other locations in the body, and most specifically the brain, where you'll see little abscesses of it growing throughout the brain. It also actually is one of the few fungi where we talk about a toxin. It produces something called gliotoxin, which actually is really great at inhibiting macrophages from phagocytosing the conidia. So the neutrophils need to be able to keep up with the hyphae to protect us, and the macrophages need to be able to inhibit the conidia. So if it is producing the toxin, that kind of knocks out our macrophages. And if you get enough hyphae that then grow out of those conidia, then that can overwhelm the neutrophils, which is kind of how it sets up infection in certain populations of patients. There are a couple different clinical syndromes associated with Aspergillus. The first one we're going to talk about is actually ABPA. ABPA is allergic bronchopulmonary aspergillosis. In this case, what happens is that Aspergillus is actually causing inflammation in the lungs and like allergic symptoms like coughing and wheezing. It's not necessarily that the organism is causing a problem, it's the inflammatory response to the organism. Because remember, we're going to come across Aspergillus all the time. It's everywhere. We can't avoid it. So it's the inflammatory response to the Aspergillus that's harming us. So that's why we can almost think of it like an allergic response, right? We consider people who are allergic to tree mold. We call that an allergic response. Tree mold is not pathogenic to us typically. And, you know, there are people like myself who get, you know, watery eyes and a stuffy nose when pollen or tree mold counts are high. Well, a similar thing can be said for Aspergillus. We're going to see a lot of Aspergillus in this world. Not everybody will respond to them, but some people will. And when they do, they have this inflammatory response that's very almost type 1 mediated and really resembles like an asthmatic response. Histologically or immunologically an allergic response. So with the asthma response, you can see mucoid impaction of the bronchi, eosinophilia certainly, and occasionally when a patient is really severe, you'll see a granulomatosis, but really it's more like asthma than it is granulomatous. When we think about ABPA, we're really thinking about two cohorts of patients most often, asthmatics and patients with CF. ABPA will actually occur in about 1 to 5% of asthmatics and 1 to 9% of CF patients. And what we see is that we get these recurrent exacerbations every time they come in contact with it. And in severe cases, as this gets worse and worse, you can see bronchial obstruction, fever, malaise, and then you can also get kind of this expectoration of the brown mucus plugs. And remember, we also see mucus plugging in asthma, so that's why it's almost kind of an exacerbation of the asthmatic response there. And as you know, in really severe cases, you can even see some hemoptysis occur. Aspergillus rhinosinusitis is kind of a similar thing that we'll see occasionally in people with basically an allergy to it. You've got nasal congestion, obstruction, sinus pressure, and sometimes even this like thick, dark colored nasal discharge that's associated with it. You can also get chronic pulmonary aspergillosis. This is a long 3 months or more condition in which the aspergillus is actually going to cause cavities in the lungs. And these cavities are called aspergillomas. Aspergillomas are also known as like a fungus ball, and that's what you're seeing pictured here to the right. In this case, the aspergillus grows in the lungs or sometimes the sinuses, which would certainly be more unfortunate since your sinuses are a lot smaller. But they're growing in this, you know, focal point. They're not invading the bloodstream. They're not doing that vascular invasion of the hyphae. They're kind of creating their own consolidation right there. It can be somewhat saprophytic in that an old lung colony can actually become colonized with the organism and then form this structure. So let's say you had a previous form of pneumonia that created a cavitation. The aspergillus might be like, oh, this is a nice cozy spot for me to hang out in. And then we have invasive aspergillosis, which is kind of what's pictured over here. In this case, this is where you get that invasion into the vasculature. And this is really associated with patients who have neutropenia, because remember, the neutrophils are the key defense mechanism against those hyphae that are what are going to destroy the vasculature. This certainly represents a significant problem for patients with chronic granulomatous disorder, or CGD, because remember, those patients, their neutrophils are unable to perform respiratory burst or oxidative burst. They're unable to kill to the best of their ability. So this would be an instance where a pathogen in a CGD patient would be really severe. It can also be a significant pathogen for, like I said, immunocompromised patients, or also patients who are on glucocorticoids, or cancer patients, because all of these patients tend to be fairly neutropenic. And in that case, you can see here, we have this patient who had kind of a sinus infection that then went hematogenously, and now we're seeing it kind of come out fulminatingly out of the patient's face. In this case, this up here, this is actually, it looks like an aspergilloma in the brain, but it's actually a brain abscess where the aspergillus got into the vasculature and then was swept up to the brain where it set up camp. Aspergillus kind of likes the brain, so that's one of the places you might see it hang out. You can also have cutaneous aspergillus when it enters wounds, like surgical wounds, burns, things like that. This really only occurs, once again, in patients with a weakened immune response, but it is something to watch out for, particularly in immunocompromised patients where it happens, because this one can actually lead to invasive aspergillosis. All right, so diagnosing aspergillosis, there's slightly different rules for ABPA versus other forms. In general, culture is the gold standard, but here's the thing, unless you've got full-on disseminated disease, most of the time the blood cultures are going to be negative. So while you would love to do culture, just taking blood will not be enough. So the best thing to do would be to look for those septate hyphae that are branching at an acute angle, which you can see over here. And then the other thing that you need to keep in mind when you're looking at culture, though, is that remember, Aspergillus is everywhere. So you can have spores that are colonizing airways, that may cause lab contamination of specimens. So that's why you actually need to see the tissue invasion or get a positive culture from a normally sterile tissue, like the brain. The brain should be sterile. So if you grow out Aspergillus from the brain, well, then the patient had Aspergillus. And I say had because if you're growing something out from somebody's brain, that's normally a pretty bad sign. ABPA, first, you're going to start by just suspecting it. And you suspect it in certain types of patients, right? We suspect it in asthmatics. We suspect it in CF patients. And then there are a couple things that will kind of add weight on that side, like a chest x-ray that shows mucus plugging or lung consolidation or bronchiectasis, along with an elevated eosinophil count or an elevated IgE in the serum. And that's just total IgE at this point. Because remember, this is largely an allergic response, ABPA. You would actually confirm the diagnosis by showing that this IgE is specific for Aspergillus. If you're seeing the reactivity or the activity to Aspergillus, then Aspergillus-mediated inflammation is what you're getting here. For treatment, there's a whole bunch of treatments here that I've listed here. The only thing I'll mention as far as the treatment goes is that I did mention that you could have these aspergillomas. If the aspergilloma is just discovered randomly and it's not causing the patient any problems, you don't always have to treat it. It could just be a cavitation where Aspergillus grew for a period of time. If it's causing a problem, obviously you're going to treat it, but they don't always require treatment. Now, if your patient is immunosuppressed or has some other underlying condition, obviously that's a different story.